All right, so the big finale here. So I'm going to talk about this specifically in our cataract age patients. And nothing that applies to this talk. And just a reminder that collagen cross-linking is not FDA approved, and riboflavin and UVA light treatments, also sort of old in the United States, aren't approved for human use in this specific procedure. But interestingly enough, if you actually look at the American Academy of Ophthalmology's preferred practice patterns, you find collagen cross-linking nicely sandwiched between intracorneal ring segments and lamellar keratoplasty. So it may not be FDA approved, but it's in how we're supposed to treat these patients. And this is a referral that I've been seeing more and more commonly in the last year. I think I've seen 3 patients in this past month. But you've got a cataract age patient with decreasing vision. They knew they had a history of cataracts, and they've had laser vision correction in the past. And now their vision sort of suddenly is no longer correctable with glasses. And the topography shows part of the story here with a pathologic irregular astigmatism and steepened Ks worse in the right eye than the left eye here. But this patient also really does have a big cataract. And so the question is then, what do we do? And what we used to do was have a discussion with this patient about their diagnosis of ectasia. And then at that point, since there's nothing we could have done about that, talk to them about cataract surgery. And depending on their age, the amount of irregularity, whether or not they're wearing successfully a hard contact lens already, you may or may not consider off-label use of a toric lens. And then after cataract surgery, if they didn't opt for a toric lens, then you'd want to fit them with a contact lens for their best corrected visual acuity. So enters the new paradigm now that we can actually do something to try to stabilize or perhaps even potentially improve their K values. We've got cross-linking to offer them prior to removing that cataract. And that may give them some different options at the time of cataract surgery and hopefully prolong their successful visual rehabilitation. So we finally have got something to do for these ectatic patients and, potentially stopping the progression of this corneal destabilization. So just a quick introduction to cross-linking. It started off as an epithelium off technique, which has been well supported by both basic science data, laboratory and animal studies, and internationally we've just seen great clinical data showing its effective outcomes. And just quick safety studies we found looking at the effects of cross-linking on the endothelium, that as long as they had enough stroma, the magic number being 400 microns, they did well. And then we looked at the effects of the corneal and conjunctival epithelium with cross-linking, and we didn't find any significant epithelial damage histologically. And then to just do a little potpourri of the clinical evidence, this was a Sentinel article in 2003 out of Germany that showed not only an improved best corrected visual acuity in 65% of patients, but we saw a reduction of Kmax in 2 diopters. So not just stabilization, but some improvement. Here's a Turkish article. The K curvature decreased by 1.57 diopters. Here in the United States, a nice prospective randomized study with a Kmax decrease of 1.7 diopters and improved uncorrected and best corrected visual acuity. A Swiss article of 2013, decrease in Kmax of 1.9 diopters, and majority had a best corrected visual acuity improvement. And that was actually in the post-LASIK ectasia subpopulation, which is nice to see. And here's an article out of the Netherlands, 88.5% stabilized or decreased Kmax with an average decrease of 1.3 diopters. And probably the longest prospective randomized study, 3-year follow-up that recently came out of Australia, again showed a Kmax decrease of 1.3 diopters and improved uncorrected and best corrected visual acuity. So we're seeing stabilization or maybe even improvement in these patients. So the epithelium off technique, very easy to perform, just sort of standard preparation for any surgical office procedure. And draping the lids and lashes, putting a lid speculum, we're removing the epithelium centrally, and then leaning the patient back in a procedure room and applying riboflavin drops every 2 minutes for 20 to 30 minutes. And at that point, we want to confirm that there's been complete corneal penetration of the riboflavin, and you can actually see it in the anterior chamber as well with that yellowish hue. And then the patient's reclined, listening nicely to the music of their choice, and a UVA light is then applied for a total of 5.4 joules per centimeter squared, which in the original Dresden procedure was done for 30 minutes. Epithelium off, which is where all the research is, a lot of the research is going in this area right now, is of course the goal because we want to avoid this. So we want to minimize our risk of infection, and this is a patient with a non-healing ulcer 1 month postoperatively. They were culture negative twice and ended up having a nice central scar afterwards. So this is what we're trying to avoid, and that's what epithelium on would provide us. So again, that's being debated right now and heavily researched, and we've got a growing body of clinical evidence that actually is supporting and some refuting points of this variation of cross-linking. But just some take-home points, just remember we've now got an extra step in there to offer patients before taking them straight to cataract surgery if they're in that, post-LASIK ectasia subgroup, which is unfortunate, and hopefully we don't see a whole lot. But I have a feeling we're going to have a little bit of influx of that when we're using those manual hansotomes that we're cutting a little bit deeper, and we're going to have that baby boomer population come through, and so we might be seeing this a little bit more in the next decade or so.
Thank you, Chris. Great talk. Great.